Right, next speaker, Dr. Parvati Banu. Her topic is laryngologist, Shushruth Hospital, Mumbai.
Good afternoon, dear friends. At the onset, I would like to thank the managing committee for giving us such a wonderful platform. So today I would be just touching about the common voice disorders, the diagnostics, and the vocal hygiene. As we all know, voice is a unique identity for each person produced by the larynx or the voice box situated in the anterior part of the neck. Physiology, if we consider, there are three voice subsystems: the air pressure system, the vibratory system, and the resonating system. In this era of super specialty, Voice Clinic is one of the super specialty clinics. It is a multi team approach and it is equipped with specialized diagnostic modalities like a stroboscope, the rigid flexible laryngoscopy. Any person having a hoarse voice persisting for more than 2 weeks needs to visit the laryngologist. Common causes being an overuse or misuse of voice, excessive drinking, smoking, upper.
Thank you, Nilima. My friend Nishi Gupta, I took advantage of introducing her, and though she doesn't need an introduction, as you can see, she's director in HOD Department of Otolaryngology, that's we call ENT, at Dr. Shroff's Charity Eye Hospital, New Delhi. She is known as a DCR woman of India, basically. So she has a skull-based fellowship from University of Malaya, Kuala Lumpur. She's operating faculty in 50 live surgical workshop at national and international level. I think big round of applause for that. She's authored and published 6 books, launched first teleotology service for community here in India in collaboration with Meditronics, organizing live surgical workshops on endoscopic sinus, lacrimal, orbital surgery for the more than 2 decades now. इतनी बुढ़ी लगती नहीं हूँ. International invited talk, numerous awards and orations, keynote, and 80 publication in national and international journals. And above all, she's a very humble and lively person. Dr. Nishi Gupta, please.
Thank you, Dr. Chanchal, being my friend. You've given that elaborate description. I don't deserve that much. And I would like to really thank this team of ladies to have really accomplished this, something that we were discussing for a very long time. I'll be talking on transnasal endoscopic management of orbital disorders, and this is my special area of interest because I work in exclusive eye and ENT hospital, and these are the kind of patients that are being referred to us. So there is a list of procedures. How much time I have? 12 minutes? 15? Okay. 15, okay. So this is the list of procedures that can be performed through the transnasal route for orbital diseases. This is case 1 of orbital osteomyelitis in 4-month-old child. As we can see, there is right orbital cellulitis, which was recurring after at least 4 courses of IV antibiotics over a period of 2 months. So when it localized to the infraorbital area, we did CT scan. There is collection along the floor of the orbit. We can also see the dead bone lying here. So we thought of exploring the child along with our team of ophthalmologists. And as ENTs, we just need to clear the ethmoidal tissue and drain this mucopurulent discharge from the maxillary sinus.
I'd like to call Dr. Shilu Srinivas, Senior Consultant, Cauvery Hospital.
Hello. So I think I have a very, I've been placed such that I am before Kalpana ma'am's lecture. All of you had lectures since morning, and I have been sitting between these two, my first ever registrar and my first ever lecturer, where I'm thinking, ye dono dekh lenge. So I am first of all so thankful for this gathering, Kalpana ma'am. So very quickly, I just wanted to convey a couple of messages. So as soon as we endoscopic surgeons talk about endoscopy, we are, okay, scope dalenge, we'll get something. At least that's what I thought about and how I have grown over a period of time. So we know that silent endoscopy came because we thought we were removing the glands unnecessarily. So we were looking at the duct-centric approaches. And then as you grow into it, even all over the world, people have grown into that, are we doing justice to the gland? And then in the 90s, most of the Europe was doing combined approaches for the submandibular gland. And later, actually, a decade later, it came for parotid. Because for parotid, most of the combined approaches become external. And for submandibular, it is easier. So we all do a head and neck surgery, so we can do them. But the whole funda was that when we are saying duct-centric pathologies, and if you have a deeper stone, what do we do? So it was all about consenting the patient, reaching to their expectations.
For the next speaker, it's my pleasure to invite Dr. Aruhana. She is a director ENT and head and neck surgery, Medanta, the Med City Hospital, Gurgaon. She has more than 45 publication in national and international journals, and she has more than 30 years of experience. Let's all welcome Dr. Aruhana.
Thank you, chairpersons. I congratulate all the lovely ladies here, especially the organizers, to make it possible. And this is just the beginning. I'll be talking on correcting the crooked nose. So mainly I'll be talking about the different strategies that can be used to make crooked nose straight. So it doesn't, if the crooked nose doesn't only affect the function or the aesthetic look, but it also works on the psyche of a patient because of the social stigma attached to it. Basically, a crooked nose is a deviation from the midline, but sometimes a depressed nose also looks like a crooked. So we call it pseudo crooked nose. Before you start working on these patients, you must analyze the face.
We are having Dr. Deepa Nair. Unfortunately, she's not here due to some last minute issues. So we'll be playing a recorded session for her. Dr. Deepa Nair is Professor and Surgeon Division of Head and Neck Oncology at Actrec Tata Memorial, Mumbai. And she has more than 75 reviewed national and international publications. Her areas of interest are management of skull-based malignancies, minimally invasive head and neck surgeries, and HPV-negative oropharyngeal cancers. We can start.
Good morning, everyone. I'm very happy to be a part of the first WAOI summit. And I'd like to congratulate Dr. Kalpana, Dr. Sharmila, and all of the team who have been working tirelessly for the last 2 months to make this event a real success. I wish I could have been with you all there, but I'm happy to participate online. I'm a professor and surgeon at Tata Memorial Center, Mumbai. And the topic of my talk today is use of adjuncts to improve outcomes in thyroid surgery. So let me just first start by saying that thyroidectomy is an easy surgery, except for the fact that there are these 4 nerves and these 4 parathyroid glands, which make our life a wee bit difficult. There is a significant risk of recurrent laryngeal injury in thyroid surgery, and this incidence can vary between 12% transient paralysis to 1% permanent paralysis in experienced hands. There are some factors which are important and increase the risk of injury.
It's my pleasure to welcome Dr. Sharmila for her insightful talk. And Dr. Sharmila has held specialist and consultant appointments in India and the Ministry of Health in Saudi Arabia, Maldives, Seychelles, and Oman. She is an advisor to the Indian Medical Association National Committee for Emotional Health and Well-being of Doctors and Medical Students since the last 3 years. She also was awarded the National Merit Scholarship by the Ministry of Education, Government of India, and the NTSC training awarded by NCRT for MBBS and MS in ENT. She is also involved with robotic surgery, telehealth, artificial intelligence technology, enabling care solutions for medicine, digital age, for public health and community well-being. It's an honor to have you here, ma'am.
Thank you. It's an honor to be here and to speak on the first Mentor Summit of WAOI. I'm so excited and the event is going on so well. My topic is spotlight on
innovation and technology in otolaryngology. Creativity is thinking up new things, and innovation is doing new things. And I think we have used, Dr. Kalpana and I, technology to achieve the formation of the WAOI and being here. And all of you have contributed in helping us to make a success with your overwhelming response. But when you use technology, there is always the con, and that is technology is a useful servant but a dangerous master because it comes with opportunity and added risk in whichever field you use it. This is point of care ultrasound. I will just point out a few innovations which I think are pertinent to the talks that we are having here, and maybe we can use because otherwise it's endless. In patients with dyspnea, head and neck, point of care ultrasound should be used to diagnose the conditions of upper airway obstruction.
Thank you, Dr. Srinivas. It gives me immense pleasure to invite Dr. Kalpana Nagpal, Senior Consultant, Apollo Hospital, Delhi.
Good afternoon, all. Hope you're all enjoying the scientific event. Now, this is an entirely new topic for most of you. Probably the reason is that robots are not available in all the hospitals. Now the number of robots have been increasing. Currently, India has 72 robots. When it started, it was only 6 or 7. So ENT is still in its infancy. Robotic surgery happens in various specialities, and we have a common robo in the hospital, and ENT, by the grace of God, has started. So Da Vinci was available to me as the robo was Da Vinci by Intuitive Surgicals. Now the time when I started, it was SI system. It was a basic model, and now we have upgraded to XI system, which has more benefits. Play the video for me, please. So these are the instrument arms and the endoscopic arm in the patient card. All the instrument arms have ports, as well as these arms can be introduced to this. And this is a surgeon console when I can sit and do the surgeries. And you can see it's a binocular vision that we get, and also a 3D vision. It is much more naturally better than the naked eye vision because you're seeing structures and with 10 times magnification. Most of the surgeries, I don't need reconstruction, I don't need to suture. So these are the advantages as I go through the slides. Apart from the glamour it really has a lot of advantages. But the indications are limited. They're slowly expanding the indications. But as you can see, it's a totally computer-assisted technology.
Next speaker, Dr. Chanchal Pal, Consultant, Apollo Hospital, Delhi. I'm sorry, I don't know more.
No need. Thank you. After mesmerizing lecture from Dr. Neelam Ved, this is a filler. So this is me, as you know. So first of all, let me welcome you all on behalf of WAOI. And thank you we are overwhelmed with your presence, and the hall is almost full. So today the topic given to me was management of allergic rhinitis in OSA. So this is, I think everybody in the audience know how to manage. This is just to sensitize you that what is the burden of allergic rhinitis in OSA. So what we are going to talk about are disease burden, recognize etiology, evaluate, manage, and see the future.
It's my pleasure to call upon the next speaker, Dr. Jyotsna Jagtap. Dr. Jyotsna is director of Dr. Jagtap ENT Hospital from Thane. She is a visiting rhinoplasty surgeon at LTMG Hospital, Sion, Mumbai. She did her fellowship in rhinoplasty under Professor Gubish at Stuttgart, Germany. She has been given the award for best thesis on endoscopic DCR surgery and has been invited as faculty in many national and international rhinoplasty workshops. The area of interest is rhinoplasty.
Yeah.
Welcome, Dr. Jones.
Thank you so much. Also, I would like to thank Team WAOI for doing this wonderful job and inviting me and giving the opportunity to speak on this dais. What can be more fascinating for us rather than the beautiful face? And as the nose occupies central place in the face, any deformity of the nose can attract unwanted attention. So my friends, today my topic of presentation is rhinoplasty and tips and tricks of doing a better job towards it. So most of the famous personalities opt for rhinoplasty to look better and attractive. However, rhinoplasty is regarded as the most difficult of all cosmetic surgeries because mastering the rhinoplasty requires a sophisticated understanding of nasal anatomy as well as the function, precise surgical technique, familiarity with many pitfalls that can lead to potential complications, and unfavorable tissue characteristic can lead to healing process which is not in our control.
So, a very good morning to one and all. It's a pleasure and an honor to be standing here in front of you to present endoscopic skull base surgery. Today, my topic is endoscopic anterior skull base surgery, an area of very special interest. Let's speak about the scope and approaches via the amplifiers of the nasal cavity, and then come to a video demo of the same. The nasal cavity is a natural pathway to the anterior cranial fossa, the orbit, the pterygopalatine, and the infratemporal fossa, as well as the frontal, maxillary, ethmoidal, and the sphenoidal sinuses. The adjacent compartments are thought to be amplifiers of the nasal cavity. The sphenoid sinus offers the possibility of reaching the anterior fossa up to the posterior fossa, right through the middle. Nasopharynx offers a path to the inferior clivus, the foramen magnum, the craniovertebral junction, and all the way to the infrapetrosal spaces. Let's watch a video of the same. I've pre-recorded a video just once to let you know the approaches that can actually be possible right from anterior to posterior in the sagittal plane, the transfrontal, transcribriform, planum, tuberculum, clival, and the transodontide.
Thank you so much. Kindly stay back. And that is the reason why we have this WAI, where you know more about the ladies doing the good job. So ladies, don't think it's lunch hour yet, because we have little surprise for you. At the back of this audience, there's a man sitting here. He silently came in, our past DMC president, Dr. Girish Tyagi. Ladies, Dr. Girish Tyagi, ladies, welcome Dr. Girish Tyagi. Before we leave for lunch, he will give us some tips about the ethics, some DMC, MCI, and NMC rules and regulation. So I'll request Dr. Kalpana to first felicitate him with a stall. Yeah. Sir, please in the center, please. Can Dr. Sharmila and Dr. Abha join? Chairperson, please keep sitting here. Keep there. You can stand for a photograph. So we can have a quick photograph. Sir, take a seat, and before you speak, I'll introduce you. I don't know, you don't need an introduction in Delhi, but I think the ladies have come from outside also. So, first of all, thank you for gracing the occasion, accepting our invitation. And he had been the past president of Delhi Medical Council, a statutory body. I thought you are present president, sir. Nevertheless, he has also been secretary to Delhi Medical Association in past, finance secretary of DMA, past senior vice president, past associate editor of DMA Bulletin, past president Indian Medical Association, Delhi zone also, past president UCMS alumni, awarded Lifetime Achievement Award by Delhi Medical Association, awarded Doctors of the Year Award by IM Headquarters, recipient of Distinguished Award at Vigyan Bhavan Platinum Jubilee Celebration. So with that, these words, I welcome you, Dr. Tyagi. And for us, he has been a mentor and advisor for all the rules and regulation and ethics in medical association. Thank you, sir. Come over, please.
I'm not the past president of Delhi Medical Council. At present, I am the secretary cum registrar of Delhi Medical Council. I am the past president of Delhi Medical Association and Indian Medical Association Delhi North Zone. Just about that, Delhi Medical Council, we received around 45 to 50 complaints per month we are receiving at Delhi Medical Council against the doctor for their professional misconduct and medical negligence. And any doctor practicing in Delhi, if the complaint, whether it is being sent to the President of India or to the state government, ultimately it will come to Delhi Medical Council, and we received complaints from all the quarter, from that Consumer Court, High Court, Criminal Court, Police, Delhi government, central government, PM office, NHRC. From all the quarter we are receiving the complaints. And at least 60% of the complaint, there is a doctor behind that complaint. That is unfortunate part. And just going through the complaint, we came to know that from the writing, from the literature provided in the complaint, from that technical word used in the complaint, it is amply clear that there is some doctor behind that complaint, and that doctor is also supporting the complainant and even pursuing the complainant to go ahead with the complaint. Even some of the time it is seen that the complainant want to withdraw, but that person or doctor didn't allow him to withdraw the complaint even. So that is unfortunate part. And just going from the experience, there is two parts. One is communication and another is documentation. If we follow 10 to 20% of communication and documentation, most of the complaints against us will be reduced. So wherever I go for that any session also, I just ask our doctor colleagues to follow. One is communication, another is documentation, third is communication of documentation, fourth is documentation of communication. We have to do this because communication is the art. In our times, it was not part of the curriculum, but after a lot of meetings with the Medical Council of India and central government, now it has been part of the curriculum. Because we don't know how to disclose the bad news to the patient or to the relatives, how to disclose the death to the relatives. So, at Delhi Medical Council, when the complaint is received, first it is put before that executive committee. Executive committee screen that complaint, and if they don't find any substance, they can dismiss the complaint at that level. If they find there is some substance, then they call the experts of the relevant specialty. They ask the statement of defense from the concerned doctor and the nursing home, and it is put where expert feel that there is no merit in the complaint, then of course if the expert feels that there is some issues involved with the complaint and it needs more deliberation, then it is sent to the disciplinary committee. Disciplinary committee is a committee which has got the sanctity of even the High Court of Delhi, Supreme Court also. It has got 6 members. Out of these 6 members, 3 are the non-medical persons and 3 are the medical persons. 3 non-medical persons are, one MLA is there, one legal member is there, one eminent public man is there, and 3 medical persons are, one the chairman of disciplinary committee, then 1 member of Delhi Medical Association, and 1 expert from relevant specialty. Because it has got the 3 non-medical persons, because of that sanctity is there. Otherwise, whether it is public or police or media, they are saying that doctors are saving their own brothers in that various fora. Since it has got 3 non-members, that means it has got the sanctity of the High Court. Because our complaints are going to that High Court. Once they are not satisfied with that decision of Delhi Medical Council, they can go to the High Court, and High Court has given the sanctity. So communication is an art. Communication should be two-way communication. Gone are the days when the doctors are Suppose they have a superior role and whatever they say, the patient are follow. Now the patient are coming aware one. The patients are aware one. They come with that after going through Google or after consulting or discussing their friends or relatives, whosoever doctors are there. So communication is there. Just one instance in one of the disciplinary committee when we call the complainant as well as the doctor. In the disciplinary committee, when there is a head of the whole because all the team members of that particular treatment who are involved are being called. So there were few doctors along with HOD and the senior resident, etc. Patient expired, of course. The father of that diseased patient touched the toe of the senior resident and abused the HOD. What was the reason? He said that डॉक्टर साहब जो यंग डॉक्टर है ये तो बड़ा अच्छा था, इसने तो हमारे को पूरा बताता था, मिलता था, बात करता था, प्यार से बात करता था, बट जो एचओडी था उसको गाली देते हुए कि डॉक्टर साहब इसकी वजह से मेरे बच्चे की डेथ हुई है बिकॉज ये तो आता ही नहीं था, बात ही नहीं करता था, घमंडी था. These kind of abuses in front of his junior, in front of his all the colleagues, in front of his non-medical persons. So this is the art of communication. कि वो even after the death, he is touching the toes of a junior and abusing the senior most person of that unit. So communication should be two-way. We should ask the patient and the relative to ask questions, whatever their queries, and then of course it should go ahead. Role of documentation is very, very important because ultimately the case, whether it is a state medical council, whether it's a national medical commission, whether it's a consumer court, whether it's a criminal court, whether it's high court, case will be decided based on the documentation part. And we doctors, apart from being are very poorly communicating with the player, and more so with the documentation part. We are doing something, we are doing the things, but we are not documenting in the parts. In one of the case, a ENT doctor who was based at Uttarakhand, he was a complainant. His mother was operated at a big corporate hospital in Delhi by a big named doctor who was a Padma Awardee doctor. When of course, the complaint, because since it was complained by that ENT doctor was the complainant, we referred to disciplinary committee. In the disciplinary committee, we call the team of doctors, along with who's Padma Awardee who has operated, along with his junior and team who was looking after the patient, along with the complainant. First thing, we ask the complainant to introduce, जो हमारे को एक normal routine होता है कि we ask the complainant as well as the doctors to introduce themselves. Complainant को कहा गया कि introduce करने के लिए, what the complainant does? Complainant introduce himself as, डॉक्टर साहब मैं दिल्ली मेडिकल काउंसिल का शुक्रगुजार हूँ कि आपने मेरे को भगवान के दर्शन करा दिए विद फोल्डेड हैंड्स, हाथ जोड़ के बकायदा. हमें लगा कि he is commenting on the working of Delhi Medical Council that after say 2 years or so we have taken up the case and asked that he is to appear in that disciplinary committee. I again asked him to please introduce himself. He again told the same thing. मैं दिल्ली मेडिकल काउंसिल का शुक्रगुजार हूँ कि आपने मेरे को भगवान के दर्शन करा दिए. We asked him to elaborate, please, what you are saying. He said कि डॉक्टर साहब, the doctor who has operated my mother, of course he is a Padma Awardee, big name, but I am seeing him for the first time. मैं बड़ा चंबल लगा कि what he is saying. He said that डॉक्टर साहब, my mother was diagnosed at Uttarakhand itself, stiff joint थे, and he was advised that knee replacement. Here also in the OPD his junior team was examining and they also advised that in the operation theatre, since I was not allowed to go inside the operation theatre, I don't know whether he has operated or not. Then we asked him that after, even when the complication occurred, your stay was increased, then of course you must have seen that doctor must be coming to that in the post-operative. He said, no, I have not seen him. We asked him, are you with your mother most of the time? He said, I was with my mother most of the time. Then we asked concerned doctor, who was a Padma Awardee, Doctor Sahab, what he is saying? Doctor Sahab ne kaha, no, I was going for the post-operative rounds, and so you ask my junior team and all. Then we asked one question, Doctor Sahab, please document in the files that you have seen the patient. In the file, no signature of the doctor was there. Of course, let us go ahead. Nowhere in the file it was meant that it was shown that case seen by such and such person or case discussed with such and such person. Nowhere in the file. So when you are not documenting in the files, it is difficult to prove that you have seen the patient, you are going through the patient. तो उसी मीटिंग में जो हमारे एमएलए साहब थे, लीगल मेंबर थे और एमिनेंट पब्लिक मेंबर थे, व्हाट आर देयर कमेंट्स? एमएलए कमेंटेड कि डॉक्टर साहब इतने बड़े डॉक्टर हैं, पद्मा अवार्ड है, इनके पास कहाँ टाइम है कि पेशेंट को देखने का, राउंड लेने का. Then the legal member who might have taken his legal degree from a remote area of online or etc., you can assume his credentials about that literacy part. He said that डॉक्टर साहब इतने बड़े डॉक्टर हैं, he will sign, इसके पास साइन का कहाँ टाइम है, he will sign only on the 2 occasions, one on the checkbook and another on the will part. These were the comments of those, you can say, the literate or illiterate person about that doctor who was a Padma Awardee, who was a big name in front of his junior mean कि जो एक MRD person से जो person होता है clerk level का, who is taking the files, and these are the comments. So documentation is very